I take this opportunity to thank the organizers for allowing me to present this paper in front of this August scientific gathering. During the latter part of the 20th century and the beginning of the 21st, vast strides have been made in pediatric cardiac surgery. Several children have benefited by the advances. But have the underprivileged children who cannot hope to have access to expensive cardiac surgery, have they benefited? This is a question mark which the globe has to answer. This presentation is querying whether there are risk factors in addition in the underprivileged children. Presented from Public Health Center in Chennai, India. The question of whether specific risk factors for the underprivileged are there, the answer is yes. They are malnourishment, anemia, and hypoproteinemia. Underweight malnutrition was common, hemoglobin percentage of less than 9 grams percent, and a packed cell volume of less than 27%, and a serum albumin less than 3.5 grams percent were taken as the cutoff value to determine whether there was malnourishment, anemia, and hypoproteinemia. The main risk factors: malnourishment formed 94%, anemia formed 86%, and hypoproteinemia formed 68%. This analysis, it's a retrospective observational analysis. I will explain presently why it is observational. Was conducted in 3 tertiary centers: Institute of Child Health and Hospital for Children in Chennai, which happens to be the largest children's hospital in the country; KJ Hospital Postgraduate and Research Center, Public Health and Welfare Society. This analysis was conducted in 3 chronological phases. They were dependent on 3 main factors. 1, the infrastructure. Second is a dedicated, trained team. And third, a hospital with multi-specialties in pediatrics. Phase 1 had 2 stages, where the equipment was optimal in the first stage and state-of-art in the second stage. Second phase had just optimal equipment, and third phase had all. The demographics was: surgery, congenital cardiac surgery formed the maximum, followed by the acquired. Congenital heart diseases breakup showed left to right shunts being the maximum number, followed by tetralogies, and which were followed by complex anomalies. Acquired heart diseases were divided as mainly rheumatic, followed by pericardial. The age-wise distribution showed the maximum number between 1 to 5, followed closely by 5 to 12, and less than 1. There was a slight preponderance of males above females. Apart from the risk factors mentioned now, risk factors which are intrinsically present for cardiac diseases were also analyzed. From 1988 to 2019, 5,653 underprivileged children were analyzed, and 23 risk factors were analyzed. The result was gross mortality reduced from 12% to 3.92% in the first phase. The change came between the first and the second stages. In the second phase, it continued to be 3.92 and reduced still further in the third phase. How did this happen? It was simply by the application of known concepts of principles of physiology and applicability and tailoring as per needs. Now let us take phase 1 in the Institute of Child Health and Hospital for Children. The malnourishment was 94%, anemia was 86%, and hypoproteinemia 68%. Malnutrition was underweight. We did nothing for it. We took these children up. In few cases, when they had to be on the ventilator, when they had to be weaned from the ventilator, we had to give them parenteral nutrition or Rice tube nutrition. Now let us analyze the pertinent features in other centers regarding malnutrition and how they managed. In most of the centers, the causes, that is malnourishment, led to increased mortality and morbidity. Addition of cardiac defects worsened the situation. Age, in simple anomalies also, it was well found. This is mainly because of immaturity, especially in the neonates. The older children, the organs were mature and they were better suited to face the problems. So far as we are concerned, we face the peculiar situation when the age was low, weight was still lower than that. We could see children 4 years of age weighing only 10 kilograms, which was underweight malnutrition. So the results were different. When we operated on a 6 kg child less than 1 year, the risks were higher. When the same child was operated on the first year or the second year, the results were better, perhaps because of the matured organs. In complex anomalies, there are some centers which recommended nutritional additions prior to surgery. We couldn't do that. These children just came and we operated on them depending on the problem involved. Fluid shifts, capillary leakage, and edema occurred are a problem in all three: malnourishment, anemia, as well as hypoproteinemia. We countered them with controlled hemoglobin, proteins, and fluid balance. Surgery, we decided, because that was the only alternative in many of the cases. There has been one reference from Texas where mortality was not a problem in underweight malnutrition. Now let us come to anemia. Anemia we tackled by controlled hemodilution. Since these children were already anemic, when on bypass, it became uncontrolled hemodilution and we had multiple organ failures postoperatively. To counter that, we used hemic prime, fresh blood, and packed cells, maintained the main artery pressure, and the priming volume was also contracted. Tube lengths were contracted, cross sections of the tubes were contracted. We used membrane oxygenators and hemofilters. These played a very important role in decreasing our mortality to 3.92%. During bypass, if we could manage to keep the hemoglobin percentage at 7.5 grams percent, or the packed cell at 22%, not allowing it to go below that, we found that the results were very much better. Gone were the multiple organ failures. In, in phase 3, we faced a peculiar situation where hemoglobin percentage and the packed cells did go down below these marks, yet nothing happened to the patient. But at third phase, we had better control over the parameters and we had better control over the entire situation. Some studies have kept packed cells at 24%, and iron deficiency anemia were treated before surgery. We did none of that. And the definition for anemia also changed from center to center. But ours was, as I have mentioned earlier. Is it a marker of severity of illness? Yes, anemia is. As you can see, it did cause mortality in the first stage but came down enormously in the second stage. Use of blood products, all of them decreased after we maintained the hemoglobin to that level and 9 grams to 10 grams postoperatively. Perfusion, local perfusion for protection, the most important was myocardial protection. We shifted to hemic cardioplegic solutions, and Del Nido solution results have been quite gratifying, followed by a hot shot for myocardial protection. There are other centers who have echoed our findings, and there is one center which did not agree with us about the age of packed cells. Packed cells, whatever the age was, they said, did not make matters worse. But in our center, we always use fresh blood and fresh packed cells. And hemolysis has been less when we have done hemofiltration. Now comes hypoproteinemia. Hypoproteinemia, if it was less than 3.5 grams, we took it as significant and added albumin to the cardiopulmonary bypass and postoperatively. But in one case, we found that it impaired healing. This is the photograph of the child who went home fine after surgery but came back after 1 month with a severe dehiscence of the superficial wound. But the deep structures were not involved. With a high protein diet and parenteral protein in hospital, the wound completely healed, but it took 1.5 months for the wound to heal. Now comes the analysis of mortality, morbidity, and quality improvement. Collaboration with Children's Hospital Boston through IQIC made a lot of difference and brought down our mortality from 3.92% to 2.73%. And during the last 6 years, we have not had deaths due to malnutrition, anemia, or hypoproteinemia. Postoperative respiratory infection, we've brought it down to 2.73. We would like to bring it down to less than 1%. Now, what was this IQIC approach to quality improvement? The knowledge and skill based on sound physiological principles. This is regarding the entire team. Methodical, precise method of monitoring and immediate correction, never repeating mistakes, and looking for challenges, empowering nurses and training our intensivists for better care resulted in the decrease in mortality and morbidity. It was a 24 hours by 7 on toes vigilance audit. The audit has been coordinated from the surgeons, anesthesiologists, intensivists, and the nurses. Now, in reduction in mortality as per RAC 1 categories shows that we have come down very much in mortality in RAC 1, 2 and RAC 3. RAC 4, we still get mortality because it's mainly complex anomalies. We hope to surmount that problem also. Then there is a group which they couldn't be stratified. Even there we have mortality. This is the area we'll be concentrating subsequently. Now, the risk factors. The risk factors, apart from the main ones mentioned, have been in cyanotic heart diseases, the right ventricular outflow tract obstructions residual and left to right shunts across the patch, myocardial protection, and RAC1 complex anomalies. This we hope to counter soon. Morbidity also, you can see that morbidity due to arrhythmia, metabolic imbalances, and electrolyte imbalances are no longer there because we have learned to identify them early and treat them straight away. Bleeding, electrolyte imbalances, age, as well as metabolic imbalances have not contributed to mortality in the recent years. Complications have been there, but as you can see, all the complications have come down in the 3 phases. We have yet to improve, we hope to improve them subsequently. This is IQIC site data analysis, which shows that our mortality is becoming low. The great factor about the training of the team which works in cohesion, in coordination, demands technical skill, decision making, preoperative preparation, echo before and after to find out what our mistakes were, and residual anatomical defects. Following up these children for memories, for higher cognitive functions, and improvement made in each segment separately, allowing for fluidity of valve studies and variability of re-interventions have taught us many lessons. Technical skill, surgical skill is imperative, as technical imperative is good or better, yet optimal results must be the outcome. The outcome can be divided as optimal, adequate, or inadequate. This helps us in self-assessment, and not only of the surgeons but of the entire group. The worst outcome, even in RAC 1, would demand a longer stay in the hospital and add to morbidity. We have gradually come out of it. RAC stratification should be simultaneously measured along with these scores. At present, we are not scoring them as in Boston Children's Hospital, but this is the method we are following, and we hope to do it in future as definite scores. So quality control helps in self-improvement and adds on to observership also in different centers. So we come to the main factors which have contributed to these results. A dedicated, well-trained team with evolving quality improvement is an asset. Deep understanding of pre-intra perfusion, surgical, anesthetic techniques, and follow-up risk factors come second. Early detection with upgraded diagnostic facilities is the answer. And decision and audit at every stage is the ultimate. Not yet formulated scores, but we are still following the scores. These learnt applications will be made to oncoming problems also. Follow up. We have been following up these children from 98 onwards, and 90% of them progressively increased weight and height from the first month post-surgical. This has been agreed upon by a few other studies also. Some studies have disagreed. They have said there is no increase in body or height yet. For us, there has been an increase. For our cases, these patients go back to the same home with the same social environment. Malnourishment continues to be there, yet they come 20% of them came back with standard height and weight as per age according to Indian standards. This study has limitations. The limitations are that it is a retrospective analysis and observational study. Phases are not comparable. Ongoing chronological study showing progress. That is, our center has kept pace with the advancement in the rest of the world. It has reaped the benefits that others have benefited. All RAC 1 categorizations are applicable, were not applicable to all the three phases. And infrastructure, we have been able to analyze the role of infrastructure, diagnostic facilities, as well as the team and the hospital. This is our result. The diagnostic in all the three phases, that is why they were not the same. Further studies on follow-up are essential. Extrapolation of our ICH can be done if necessary. And financial self-sufficiency is our goal. There are some home truths which we like to share. Expensive cardiac surgery is unavailable for underprivileged. The right to life is their fundamental right. India is a sovereign, socialist, secular, democratic republic with unequal socio-economic status. Alternate methods are multi-source funding. We are grateful to the Government of India and other countries for helping us through this. We are aiming for financial self-sufficiency. That is our goal. Equality is aimed at through fraternity and a holistic care. We bring children, train them and treat them and send them back free of cost. We have method of funding. We have a revolving funding pool from which we are performing surgeries, and we hope to improve further. So, what is our future? Future is we have to assess our residual defects, find out biomarkers. Metabolomics is a new field which I think will be applicable to these children. There are complex challenges we have to meet, and our hybrid procedures, joining hands with the cardiologists as it is, coordinating with them has reaped plenty of benefits, and we are keeping abreast with modern advances. We conclude underweight, malnourishment, anemia, and hypoproteinemia, when managed, can improve outcome. Follow-up showed improved growth in spite of the same social background. IQIC standards should be applicable for further quality improvement. Combination of state-of-art infrastructure, a well-trained, dedicated medical team in a hospital with pediatric multi-speciality facilities is inimical for quality and quantified outcome. We are quite convinced at the end of this that these are the most important factors. Further detailed study is required to determine long-term outcome on growth. We acknowledge the hospitals, Institute of Child Health and Hospital for Children, KJ Hospital for Postgraduates and Research, Public Health Center, Children's Hospital through IQIC, Dr. William Norwick's team that helped us to improve our team, and the other visiting teams which have contributed to our knowledge and skill, donors and funding organizations, Indian and global, who have made it possible for us to perform these surgeries, and our external and internal audit team, which has helped us to be transparent and accountable, and several kind-hearted donors who have made this project possible. Thank you.